Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. Today's episode discusses COVID-19 a year later. Our goal is always to inform and start conversation.
457,762 is the number of souls or lives lost from COVID-19 according to the CDC as of February 2021 in the United States. As of February 2021, there have been 104,956,439 confirmed cases of COVID-19, including 2,290,488 deaths reported to WHO worldwide. No one could have imagined that this would be the state in which we would be currently living. I remember telling a patient at the beginning of 2020 that the coronavirus was a strain of a common cold, more like the flu. I reflect back on that statement given from the local pulmonologist, realizing we were all wrong, really wrong.
According to the CDC, coronaviruses are a family of viruses from illnesses like the common cold, SARS, and MERS. The COVID-19 virus was declared a pandemic in March 2020 by the WHO organization. Now in 2021, viruses consistently change through mutation. Ashley and I made reference to this in last year's COVID episodes. New variants or strains of the virus are expected to occur over time. Sometimes variants adapt or die, and other times new variants adapt and persist. According to the CDC, multiple variants of the virus that causes COVID-19 have been documented in the United States and globally during this pandemic. They seem to spread more easily and quicker than the other variants, leading to more cases of COVID-19. The United Kingdom has a variant called B.1.1.7. South Africa has another variant called 1.351, and Brazil has a variant called P.1.
And these variants have made their way into the United States.
All of them, all the variants have now been confirmed.
And so we wanted to update our signs and symptoms. Of course, our very first episodes that we launched for this podcast were on COVID-19. That was not what we thought our first podcast episodes were going to be. And actually, we rearranged everything because when we first thought up this podcast, there wasn't a pandemic.
Absolutely.
However, things change and we have to adapt. So that's what we did. If you go back to listen to our first episodes, it was a 3-part series, and each one broke down something a little bit different. You can look at the descriptions to see which one each
Absolutely.
one's about. But we're going to update what the signs and symptoms are that we know now. So we know that symptoms may appear 2 to 14 days after exposure. And people with these symptoms, I'm going to list them, may have COVID-19. Fever or chills, cough, shortness of breath, difficulty breathing, fatigue, muscle or body aches, headache, new loss of taste or smell, sore throat, congestion, nausea, vomiting, or diarrhea. Now, you don't need any of those to have COVID-19. One of those could be COVID-19. You could have all of those and not have COVID-19.
Absolutely.
So this is kind of the problem that we're in with our healthcare system, unfortunately. Emergency warnings for COVID-19 and really anything that you have is if you have trouble breathing, persistent pain or pressure in your chest, if you have a new onset of confusion or altered mental status, inability to wake or stay awake, blue lips or face, those are like call 911 or get somebody to take you to the nearest emergency room.
The progression and long-lasting effects of COVID-19 are still really to be known because we're now just in what I would consider the middle of it.
Yes.
Last year, we were in the beginning, and we know some now, a lot more than what we knew a year ago, but there is still so much more that we're learning through this process.
Do you think that we know a lot more now than we knew then?
I think through process of elimination, I think we do.
Okay.
Of course, I still feel like there needs to be more and better testing.
Right.
I think we've realized that has not been a consistent. If somebody can go 3 times and be negative and then go on the 4th time and test positive, something's not right. So I think we know some things more now than we did then.
Okay.
So do we still have like a long way to go? Absolutely. Absolutely.
For sure. It was interesting. I had a patient the other day and I needed to check her INR. It was 5, which was a little high. So I called the pharmacist that helps us manage INRs, and she had a recent COVID infection and was also recently on an antibiotic. So in my mind, I'm like, well, of course it's high. She was just on an antibiotic. Makes sense. But she had been off the antibiotic for 8 days. And so I was kind of like, well,
she should have been leveling out.
She should have been a little bit lower than that. So when I was talking to the pharmacist, I was going through everything with her. And I said, I just really didn't know what to do. Because, usually we manage it on our own. We alter the dose on our own. We don't need
we
to
have
call.
protocols.
Yeah. We don't need to call a pharmacist for high INR. But there was just something that just didn't set right with me, especially because she recently had, a COVID infection. And it's funny because she told me, she said, it's funny that you mentioned she just had COVID. And I said, well, she did. That with bronchitis. Her primary care doctor said she had bronchitis and COVID and gave her an antibiotic and steroids and sent her home. And she said that from what she's noticed, anybody who's had a recent COVID infection, 4 to 6 weeks recent, their INRs are always 4 to 5.
That's more than we knew.
I'm like, what?
A year ago.
And she's like, I'm like, what? Why? She's like, we don't know why. Because of course, I'm that type of person. I'm on the phone with this lady. She's got other things to do. And I want her to explain to me why this person's INR is at 5. It's just who I am. But it was just very interesting to hear and to learn that. So I'm sure I'll see it again and it'll trigger the same kind of response. And she made a very minimal adjustment. She said, I bet you when she comes back early next week, it's going to be almost fine. So I'm curious, but
to see how that is. Well, the reason why I say that we know that now compared to last year, in the beginning, we knew that people were throwing clots and a lot of people were passing,
right?
Because of it. And, our pulmonary doctors here had already made that correlation.
Yes.
So I do feel we know more today than we did last year. But like I said, I think we're in the middle of it still, and there's still so much more that we have to know.
Agreed.
The long-term effects, and all that good stuff. And with that being said, even patients who have had mild cases of COVID can experience long-term symptoms. The most common long-term symptoms are fatigue, chest pain, shortness of breath, joint pain, and cough. The next list is of symptoms that keep lingering. That would be difficulty with thinking and concentrating or brain fog, depression, muscle pain, headache, intermittent fever, and pounding heartbeats, also known as heart palpitations. One of our providers actually contracted COVID-19. And this has been, for her, probably 6 weeks out now. And she still says that she has brain fog.
Yeah, we've been seeing a lot of patients, younger patients, that are coming in with tachycardia and palpitations. And I'm talking young, late teens, early 20s, young, with no comorbidities. They're like healthy, young, normal, I could say kids, but young adults that are coming in with 140 tachycardia. Like not just like, I'm staying at 110, 120, which still isn't great, but like they're bad, pre-syncope, like it's an issue post-COVID.
And I think that's one of the things, like I said, when we're just in the middle of it, like the long-term effects, like we still don't know. Like if you catch
Mhm.
COVID-19, is that now a pre-existing condition? But that's like
It's
a
funny
whole
because I
nother...
am putting it in patients' past medical history because I don't know the answer to that. But
Yeah.
it's funny because I'm like, and nobody told me to. I'm just like, I feel like it's
Well,
relevant
it's important.
until we know it's not. And, we
Exactly.
can delete it next time if it's not.
The less common but more serious long-term complications are blood clots, which, we just kind of talked about. COVID-19 can put patients in a hypercoagulable state, increasing their risk for clots. And while large clots can cause heart attacks and strokes, other parts of the body get affected by blood clots. And those include the lungs, the legs, the heart, and the kidneys. And COVID-19 also weakens your blood vessels and can cause them to leak, which contributes to potentially long-lasting problems with your liver and your kidneys.
Mm-hmm.
With your heart, it causes inflammation of the heart muscle. So, imaging taken even months after recovery from COVID-19 has shown lasting damage to the heart muscle and includes patients who had a mild case of COVID-19. A lot of heart damage caused by COVID-19 is thought to come from very small clots that blocked capillaries in the heart muscle. And this can increase the risk of heart failure and other heart problems in the future. A less common but more serious long-term complication for your respiratory system, your lung function can have abnormalities. Pneumonia that is associated with COVID-19 can cause long-standing damage to the alveoli, tiny air sacs in your lungs. The resulting scar tissue can lead to decreased lung function. With renal acute kidney injury, African Americans have increased morbidity. The cause of acute kidney injury in COVID-19 is multifactorial. Cardiorenal syndrome, particularly right ventricular failure secondary to COVID-19 pneumonia, might lead to kidney congestion and subsequent AKI. And just as well, left ventricle dysfunction might lead to low cardiac output, arterial underfilling, and kidney hypoperfusion. Another possible cause of AKI involves SARS-CoV-2 related immune response dysregulation, as indicated by observed lymphopenia and cytokine release syndrome. Other factors that may lead to AKI include rhabdomyolysis, macrophage activation syndrome, and the development of microemboli and microthrombi. And this happens with hypercoagulability and endotheliitis. Dermatological side effects include hair loss. Hair loss is normal after an acute viral illness. This typically happens several months after the illness has passed. The good news is the hair returns to its normal shedding pattern after about 9 months. Neurologically, smell and taste problems, sleep issues, and difficulty concentrating and memory problems still exist. Even in young people, COVID-19 can cause strokes, seizures, Guillain-Barré syndrome, and COVID-19 can increase the risk of developing Parkinson's disease and Alzheimer's disease. Psychiatrically, depression, anxiety, and changes in mood have lasted. Many patients that have recovered from SARS have developed chronic fatigue syndrome, which is a complex disorder characterized by extreme fatigue that worsens with physical or mental activity, but doesn't improve with rest. And since COVID-19 is similar to SARS, this could also impact patients with COVID in a similar way.
Mm-hmm. So there are some new treatment options since the last podcast. Back in April of 2020, the hydroxychloroquine and azithromycin with convalescent plasma were in the news, I think, every day.
It was the news.
That's a very good way to put it. And I wish I could say that we have a foolproof plan now for treating COVID, but that is not the case. But fortunately, I think that we've come up with some protocols that our healthcare teams are now more comfortable with, but it's still speculation. There's still nothing that's FDA approved to treat COVID.
Everything has been pretty much emergency
Yep, an
use.
emergency use authorization.
Mhm.
So for mild symptoms, patients usually recover at home with supportive care and isolation. If a patient is at high risk because of comorbidities, a suggestion of maybe having a pulse ox would be beneficial, just to keep an eye on their oxygen levels to make sure they're not dropping, because that would mean that they need to go to the hospital. And then after that, you have moderate to severe, which is kind of grouped together. And these patients really need to be monitored closely. Some need to be hospitalized. If the patient has severe infection, they will need to be hospitalized. If the patient is thought to have a bacterial pneumonia, empirical antibiotic therapy is reasonable, but should be stopped as soon as possible. Empirical treatments for influenza should be considered when it's flu spreading season and the results are still pending. COVID replicates more quickly just before or soon after symptoms onset. Therefore, antiviral medications like remdesivir and antibody-based treatments are probably most effective if they're used early on.
Which typically is the case with anything, even with the flu. Like, you need to get your Tamiflu in
Within
like
the
day
first
2.
Yeah, within the first 48 hours.
Yeah.
Mm-hmm. As the disease progresses, hyperinflammatory and hypercoagulable states are thought to be the cause of clinical complications. So in this stage, of course, they're going to do the opposite. They're going to do anti-inflammatory medications, immune modulators, and these increase the immune response. Anticoagulants or a combination of treatments that may be more effective in addition to the antivirals that the patient may be on.
So I think looking back, from last year,
Mm-hmm.
I think we know a lot more than what we did 12 months ago.
I think I'm just still kind of...
I think we're in the middle of it.
Yeah.
And there's still so much more to know.
Right.
So I don't think we'll really grasp it all until it's
Probably
over.
years later.
Yeah.
Sure.
Or if it's, ever over. Right now, people are saying, what if this is a seasonal thing? What if these variants are kind of like what the flu is currently?
What if they stayed in their lane and didn't pop my bubble?
I hear you. Sister.
But I mean, I think one of the most, I say irritating, but it's really just frustrating things in healthcare as a nurse is I don't know the difference between a cold and a flu
and
or
now
COVID.
Absolutely.
I mean, there's no distinguishing factors at all. I mean, you have people that are getting tested and testing positive only because they were exposed to somebody who are absolutely asymptomatic.
Mm-hmm.
They're testing positive. But yet we have people that are sick that are intubated in the hospital with everything that looks like COVID that are testing negative.
Absolutely. It would be good to...
There's something wrong there.
Yes, it would be good to have a test that could differentiate this from the flu, like a one swab.
Yeah, I think they're trying to get something like that out.
Yeah.
That would test for flu A and B and COVID.
That would be awesome. And what was also surprising to me within these last 12 months is that the flu rate, which everybody thought this was going to be like a flu-rona situation.
I don't understand that just because...
I do, though.
I don't, because we're all wearing masks.
Well, yeah, I know in the beginning they thought it was going to be really bad.
Oh,
but
yeah.
Now that, people are like, oh, it's not that bad. I'm like, dude, that makes sense because we're all hand washing and wearing masks.
And social
distancing. So this should be a lesson, period, to everybody. Because if you're not getting your flu shot, and you can still get the flu, but you should have been washing your hands from Jump Street. You should have been social distancing from sick people from Jump Street. And that mask is not going to hurt. So my goal from this is hoping that even when COVID goes away, when flu season turns, the corner, that we're still practicing these things that we now scientifically know reduce the flu.
Well, and we've seen it on our social media pages. So many people stating things like, I haven't diagnosed any RSV or flu yet.
Well, I wonder why.
Like,
Because
well,
we're social distancing, we're
right.
washing our hands, and we're wearing face masks.
Yep. So some nursing considerations, of course, travel history, which I know it's a pandemic and it's everywhere, but there are still certain places that have more spread
And
than
different
others.
variants. Remember,
Right.
some of these are from the UK, Africa, Brazil.
And then physical exam, and you're just looking for all those symptoms we went through: fever, chills, cough, shortness of breath, headache, fatigue, body ache, sore throat, loss of taste or smell, congestion, runny nose, nausea, vomiting, diarrhea, the whole gamut. If they're sick, they should be at home. That's what that just said.
Absolutely. Please do not share your cooties because I don't want them.
Yes.
Keep them at home.
Mm-hmm. Some nursing care plan and goals. And we got this from everynurse.org. I actually really like this website.
I do too.
You want to establish goals and interventions. You want to start assessing altered skin integrity risk, fatigue, impaired comfort, gas exchange, nutritional needs, and nausea. So if patients are getting to the point where they're really sick and they can't take care of themselves, you just got to make sure that you're monitoring every step along the way and that you're keeping up with their needs, which I think is
What
second
we're supposed to
nature.
be doing.
Yeah. Preventing the spread of the COVID infection, providing information and education about COVID-19 and managing it to patients and or their family members if they're in there, reducing fever, restoring normal respiration, and easing any anxiety and fear. I mean, if a patient's in the hospital and they're told that they have a COVID infection, people automatically think the worst.
Absolutely. And it's not just for those who may have mild cases. Can you imagine how your patients who are being told that they're going to be vented psychologically feel when
Sure.
we know the cases are higher for death when they are vented from when they're not?
Mm-hmm. And this is stuff that most patients wouldn't have known normally for a disease process or an infection. They don't understand what sepsis looks like and what the protocol is for treating that at a hospital. But since this is plastered all over the news, it is educating the public, but it's also given them
anxiety.
Yes. So some nursing interventions, you'll just want to make sure that you're monitoring vitals, including oxygen saturation, managing the fever, maintaining respiratory isolation. That's probably mandatory at your facility, enforcing strict hand hygiene, and of course, education. I mean, there's just no way around that. And again, that is from everynurse.org is where we did get that information from. And I like the website. So
join us next week as we discuss the COVID-19 vaccinations that are becoming available to the public. Please visit us at www.thenursingpostpodcast.com for our references. And be sure to subscribe to our podcast using your favorite platform and leave your thoughts and comments. Thanks again for listening to The Nursing Post.